Good morning. This is Dr. Rutledge, and I'm going to give you a little talk today. I hope you'll find interesting. One second as I get set up. Okay, and share screen. All right, we're going to talk about the mini-gastric bypass and 4 stories and 4 somewhat radical ideas. 5 minutes each if we get through this okay. The 4 topics are understanding or misunderstanding the Mgb mechanism of action. In my mind, when we created it, I guess now about 25 years ago, the Mgb paradox. There's been good and bad reports on the Mgb. And then we'll talk about 2 topics in the Mgb BP limb length section. And then we'll talk about the Mgb original technique and the new Mgb2I. So misunderstanding the Mgb mechanism of action, it's not a sleeve. So the Mgb is nothing more than a collis gastroplasty and a Billroth 2 polya type, along with a 200 centimeter jejunal bypass. And so it's basically plain old general surgery, although there's been some confusion about that. The mechanism of action, I think, is kind of clouded by some of the obstructive type surgeries like the band and the sleeve, but basically the Mgb is designed intentionally from top to bottom to be non-obstructive, eliminating the reservoir function of the stomach. And as I say, it's not a band or a sleeve or a VBG. It also includes type 1 and type 2 dumping as foundational components. And what's missed by a lot of surgeons that I talk with and patients is that it's designed to have fatty food intolerance, leading to some amount of malabsorption if the patient violates that approach. And so here we can see graphically, the Mgb looks a lot like a collis gastroplasty, and it's designed to be a polya type wide-based gastrojejunostomy site. We know that we want rapid gastric emptying. And for example, numerous studies have shown that the Billroth 2 for post Whipple reconstruction has lower incidence of delayed gastric emptying, and that's what we want. We want the Billroth 2 to speed gastric emptying. That's the goal of the Mgb. We want dumping in those cases where the patient might violate an ideal diet. So again, just a reminder, what we want is fatty food intolerance and fat malabsorption, and that's designed not to cause malabsorption, but to modify the diet. It's an aversive conditioning, so to speak. The second topic is the Mgb paradox, and is the Mgb good or is it Mgb bad? And so some surgeons, including myself, have reported excellent results, but other surgeons, such as the Y-Omega trial, or a recent report from Australia last year, talked about 10% of their patients within a short period had to be reoperated for reflux. Well, that's obviously terrible. On the other hand, excellent results have been reported from all around the world, and the Mgb seems to be growing all around the world and maybe even knocking on the doorstep of the United States. A good example is from Dr. Lee. His study showed in evaluating the results of a revision operation for weight regain or inadequate weight loss, that the weight loss was far better for the Mgb patients, who lost 77% of excess weight loss as compared to only 32% excess weight loss in the Roux and Y group. And there are other studies that we can look at. But if there's, what is this operation? If sometimes we get reports of 0.3% bile reflux and other times up to 1 in 3. Well, the Y-Omega trial is similar. There's diarrhea in 20% of patients. Well, how can that be when we don't see that in other series? They also reported other bad outcomes. And here's some technical examples. What we think is going on is sometimes the surgery is modified, and some surgical approaches might not be as effective or as safe as others. And so the possible explanations when we think of this paradox is really simple. The surgery itself could be flawed, and that's certainly possible. Maybe like the lap band, it will be popular, and then once it's recognized to have its problems, it'll be abandoned. On the other hand, it's been around for a long time and seems to be growing, so maybe that's less likely. The most common thing in my mind is surgeon's technique, and the other thing is postoperative management. So those things would be topics I'd love to talk about in more detail. Here's another example of a twisted pouch, and you can imagine that be partially obstructing, and the patient might have severe reflux, etc. So technical errors might lead to bad outcomes, and there might be those surgeons trained as sleeve or Roux-en-Y surgeons adopting MGB with maybe might vary their technical approach. The next section is to talk about BP limb length, just two topics really quickly. There's a discussion about BP limb length, and we'll kind of make a case for the fact that longer BP limb leads to more weight loss. And the second thing is the malnutrition and death occurring after a lot of the distal bypass surgeries, including the MGB. And we'd like to point out it's probably not BP limb length, it's small intestinal bacterial overgrowth. And we hope to bring that to your attention this morning. Number one, longer BP limb leads to more weight loss. Basically, if you eat more fat, you gain more weight. Therefore, eating, digesting, and absorbing less fat should lead to more weight loss. And this is known since 1965, when the famous surgeon Dr. Thomas Starzl reported a study where he impaired fat absorption with Billroth-2 and study and increased afferent limb length, that is increased bypass, led to increased fat malabsorption. That's what we see. That's what's designed into the MGB. So for example, normal fecal excretion in his study was about 2.4% of the fed ingested fat. And as the BP limb length increased from 30 to 60 to 90 centimeters, the excess fat in the stool increased in a basically roughly linear fashion. So longer BP limb, greater fat, and also concomitant weight loss. In addition, studies from Dr. Kular, myself, and others demonstrates that there's a fairly direct relationship between the MGB and outcomes. Here's a couple of brief examples. So this is BP limb length in Dr. Kular's data at around 10 years post-op. And what we see is the longer BP limb results in a greater delta hemoglobin A1C. So more is better. And similarly, here's his data, 10-year follow-up. And what we see here is that longer BP limb is greater weight loss. The next topic is that what's wrong with the MGB. It gets these reported cases of death and malnutrition, and my opinion, maybe potentially mismanagement, misdiagnosis leading to the complication. So we'll go into that briefly. Basically, to remind ourselves a little bit, this is not absolute data, but Dr. Takino, who I have a lot of respect for, reported the average small bowel length in his study was around 23 feet or 690 centimeters. Short bowel syndrome, patients can do fine and live independently if they have a minimum of 60 centimeters, around 2 feet of small intestine. So short bowel syndrome patients only need about 2 feet of small intestine. The MGB, even in the more aggressive 6 foot or 200 centimeter bypass, leaves a residual small intestine of 16 feet. If short bowel patients need to live a healthy life off TPN, they only need 2 feet, then it's hard to call the complications of MGB or BPD or others related to short bowel syndrome. So we won't go into that more detail, but in short, here's a little discussion about blind loop syndrome from 1961, again from Dr. Starzl. Why is that I only know about old research? Basically, the diagnosis usually only occurs after months or years of disability. There's steatorrhea, malnutrition, and hypoproteinemia. These all match up with the diagnosis of some of the disabled patients after MGB. Again, what we're saying here is not that this is a surprising or unexpected complication. This is what has been seen since 1961, reported by Dr. Starzl. We should know that. So, for example, it's not the short bowel syndrome. Here's a further comment from that paper. Medical treatment is available, including antibiotics, but definitive early surgical correction was recommended by Dr. Starzl, and it's really been echoed by me since 1997. It doesn't mean that's the only treatment. Now that our surgeons should be more aware of the appropriate diagnosis and treatment of SIBO, this should be a better available option. But it's SIBO, not BP limb length. It's not short bowel syndrome. That's not the underlying diagnosis, in my opinion. And I urge you to contact me if you face one of these difficult patients. Finally, I'd like to announce we're bringing forward the MGB2I, and it's exciting. Basically, it's true to the original Billroth-2 general surgery idea and the MGB anatomy and physiology. The goals are to decrease risk of bleeding, and leaks, decrease operative time, decreased risk of reflux, marginal ulcers, and perforation. And briefly, here's the idea that complications such as death and bleeding are uncommon, but they still occur and they can be deadly. So the goal of the MGB2I is like the MGB, we want to remove the reservoir function of the stomach. That is, we want to convert the stomach into a colus gastroplasty, essentially an extension of the esophagus. In addition, we want to avoid the EG junction and the sling and clasp musculature and leave the fundus pretty much alone. We'd like to extend the length of the gastric pouch by 30 to 50%. That will decrease reflux, we think. And we like to improve the blood supply of the GJ anastomosis by sparing the lateral gastroepiploic blood supply. We think that'll decrease stricture, reflux, marginal ulcer, and perforation. We'd like to also increase the gastric outlet, and that increases dumping, which is the components of the surgery, and decrease staple line and bleeding leaks, and make easy revision and reversal, and allow it to be easily tailored from normal thin weight diabetics to super obese. Here's an example of the increased distance. So you can see the old Mason loop, which was a disaster, is here. Some non-MGB SAGB surgeons are doing it here. MGB should be at the crow's foot, and now we're moving it to the greater curvature, sparing the gastroepiploics. That's one of the modifications of the MGB2I. In addition, Dr. Ilan, who I work with, has modified the surgery by putting the staple gun in from the lateral aspect, and that gives us a more wide open gastrojejunostomy for the efferent limb. So here's an upper GI follow-up, and you can see the esophagus, the EG junction, and the proximal gastric pouch. And here we can see the gastrojejunostomy and the efferent limb. So that's it. Hope you enjoyed it. The 4 topics again: misunderstanding or understanding the Mgb paradox, good versus bad, BP limb length. It's not the BP limb length, and the new MGB2I. So thanks all very much.